Right, okay. So welcome to this session. This is the third lecture in the series of lectures which covered heart disease in pregnancy. Okay. The first lecture, you would remember that we went through a general sort of general principles of managing heart disease in pregnancy, and I gave you an overview of everything. The second, we concentrated on aortic problems as well as mitral valve problems, right? That's what I remember, right? So we covered both those things: aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. So those are the ones which we covered. So the final two things I want to, two or three things actually we need to look for, which we see, is cardiomyopathy and ischemic heart disease and Marfan's. So those are the three things that you might need. I just want you to understand the very general principles of these diseases, and that should cover all the almost all the heart diseases that you would get at MBBS level for you to answer your questions and do, manage a case. Okay. Remember, children, at MBBS level, what y'all are expected to be, y'all are expected to be safe doctors, because you're going to have get your MBBS, and then initially you are going to work as interns in our country, in Sri Lanka, as interns. So we expect you to know the general things as well as to be safe doctors, so that you function as a very safe doctor in the ward. That is what we need from you all, right? So therefore, we don't expect you to understand very complex issues of cardiac problems, because they will be managed by the relevant specialists. Even the obstetrician does not manage them themselves. So there will be a multidisciplinary input, right? So going through that, let's now go on to cardiomyopathy. Now, cardiomyopathy, some of the patients, if they meet you in the pre-pregnancy clinic, some of these patients would have had a history of peripartum cardiomyopathy. That is cardiomyopathy just before the delivery or even after delivery, right? Postpartum cardiomyopathy. So they would have had a history of cardiomyopathy, and they will come to you with a diagnosis card and, okay, doctor, I have this. Now, what is the problem with past history of peripartum cardiomyopathy? Is that these women might develop peripartum cardiomyopathy again. Now, I'm talking about the pre-pregnancy clinic, again in the next pregnancy. What is dangerous about it is that it can progress on to heart failure, and there may be arrhythmias, right? And eventually they might end up with death, right? So it can be progressive. The heart failure can become progressive, and it can end up with death. So in these women, of course, as a pre-pregnancy counselor, you will need to tell them, look, you do have a risk of developing cardiomyopathy again. And if that happens, it can progress, and also it can cause death even. So some of these women might decide not to go through that risk again, because of course they would remember what they went through in the previous pregnancy, right? So they will come to say, okay, doctor, can I get pregnant again? And then of course you need to discuss the risk. Not only that, you will also have to refer them to a cardiologist for them to discuss the relevant risk about a repeat peripartum cardiomyopathy, because there may be remnants or problems that may have been left over from the previous problem, right? So therefore, definitely, if they are in some form of, there's residual problems, right? And if there are in forms of heart failure, or if the heart was left damaged and there are residual problems, then definitely pregnancy probably is not indicated, and you might need to counsel them to say, look, it might be risky to get pregnant again, okay? And of course, there may be patients who are going to come to you with the pre-existing problem. And then if they are in heart failure, or there are signs and symptoms of heart failure, right? If they are symptomatic, definitely pregnancy is not indicated at this point of time, right? So these are all pre-pregnancy counseling. And as a pre-pregnancy counseling measure, of course, as with any cardiac disease, right, in the past, or if there is cardiac disease present now, you need to assess in the pre-pregnancy clinic the symptoms related to a problem, right? And so there is shortness of breath, dyspnea, especially at breast at night, right? And any other things, you have to assess the symptoms and carefully document them, because each visit, if she becomes pregnant, each visit she comes, you have to find out whether there are new symptoms or whether whatever she had is progressive, right? In which case you might need to seek expert help, but the first people or the first doctors that the patient is going to meet are the junior doctors or maybe the consultant, but whoever it is, an obstetrician or somebody related to obstetrics, and then that patient will need to be referred on to say, look, this woman is developing new symptoms, right? So therefore, we need to be able to do that. Next comes, remember, if it is hypertrophic cardiomyopathy, if the diagnosis, that can have a genetic component, as you remember, right? It can be autosomal dominant, right? So therefore, these patients, right, you need to remember that there is a autosomal dominant inheritance, right? So therefore, we have to counsel them. So they will need to go for genetic counseling as well, as to if they are planning a pregnancy, then a proper genetic counseling needs to be done for these patients about the possibility that their baby also might have hypertrophic cardiomyopathy. And remember that when you're talking about cardiomyopathy, that is something that you need to remember when you are in the pre-pregnancy clinic, right? The next step is, of course, the assessment. Now, the assessment is always multidisciplinary, right? As with any cardiac disease, remember from each lecture I told you, the assessment is multidisciplinary, and that needs to involve obstetrician, needs to involve a cardiologist, might need to involve an intensivist, right? And these are the ones that will do the initial assessment. How is the assessment done? We discussed this already. She will need ECG. She will need an echo to look at all the functions of the ventricles, heart, the output, the chambers, and everything, right? She might need an exercise ECG, right? She might need different type, maybe an MRI to check the functions of the heart, right? And then overall, the chest X-ray to, of course, that is a very rough way of looking at the size of the heart, right? But the rest, the echo and the MRI, all those can assess properly the functions as well as the sizes. And then overall assessment and the decisions will be taken by the cardiologist about the possibility whether it is risky for her to get pregnant again or whether it is possible for her to get pregnant again, right? So these are the ones that we will assess in the pre-pregnancy clinic, right? So that is, remember, those are the points that you need to remember, okay? Right. In general, of course, all the rest must be, as with any pre-pregnancy clinic, all the rest of the things must also be discussed. But these are the specific things that are related to cardiomyopathy, okay? And despite all these, if they do get pregnant, right, and they come to the clinic, that is the first trimester, then of course, again, the same thing. Document all the symptoms, right, or what they're having it. Check for heart failure, right? Symptoms and signs of heart failure, which you know what to do, right? Check for symptoms, especially ones that are at breast. Then put them in the NHYA class or the modified WHO criteria, which I put on the Telegram group. You know, I put a small, PDF small document about the modified WHO classification of the functional class in pregnancy, right? So you assess them with that and then properly do a multidisciplinary team meeting and assess this patient. Sometimes in this, they might recommend a termination at this point, right? Saying that this pregnancy cannot be continued and that she might die. And therefore, if she's already in heart failure and if she's symptomatic, then they might recommend a termination in the first trimester, right? But of course, logistics are a problem when termination is recommended. A psychiatrist will need to get involved to saying that because legally there are a lot of restraints and certain moral and ethical problems are as well in termination. So in Sri Lanka, it is not a very easy thing to carry out terminations during this. So, but sometimes if the mother's life is in danger completely, so these terminations may be carried out after assessment and after discussion with a lot of specialists in all relevant fields, right? As with any other pregnancy, the dating, nuchal translucency, screening for different problems, right? So all these will be done in the first trimester, but generally, immediately what is checked is the status of the heart, the echo, all the investigations are checked for the status of the cardiac disease, right? So from there, it goes on to the second. Now, what is very important is during pregnancy, the assessments are more frequent, right? Usually, once the initial assessment is made by the cardiologist and everything, for up to the second trimester, normally they'll be seen every 2 to 3 weeks or maybe monthly, at least until about 20 weeks. They should be seen every 3 weeks to 4 weeks with continuous assessments by the cardiologist in each visit, okay? And then they go on, and then in the second trimester, what needs to happen is the normal visit, plus, of course, as I told you, each visit, there must be a cardiology assessment, and then the visits become more frequent from 20 to 28 weeks. Normally, it is every 2 weeks, right? And as a general principle, from 28 weeks onwards, it is every week. So this is different from a normal patient that is assessed during pregnancy, right? So, of course, during the 20 weeks visit, right, all the rest of the things like anomaly scans are done, all the rest of the things are done in conjunction with the cardiac assessment, okay? Remember, these patients by now may be on different kinds of medication, right? So they may be on different kinds of blockers, different kinds of cardiac drugs, right, as prescribed by the cardiologist. And therefore, these fetuses, especially if she's on beta blocker, these fetuses may have growth restriction or small for gestation age. And therefore, the fetal monitoring needs to really start with serial growth assessments. And if small for gestation age is detected, then the Dopplers also will come into play, right? So serial growth assessments can start from about 24 weeks, 28, 32, 36, every 4 weeks, or even every 3 weekly. These growth assessments will need to start for the fetus, right? So that is the monitoring of the baby. And of course, different kinds, because they may be on beta blockers, so medication that can cause growth restriction in the fetus, right? So pregnancy is continued from about 28 weeks. It has to be weekly assessment. And then we come on to the delivery part. Sometimes if there are problems with possibly, if there is a risk of thromboembolism due to this disease, they may be also be on thromboprophylaxis and different kinds of anticoagulation as well, right? So these are, of course, decided by the, remember, I spoke about the way anticoagulation is used during pregnancy. Remember how warfarin is used, how heparin is used, how low molecular weight thinner, that I have discussed in the first lecture very comprehensively for you to understand how anticoagulation is managed during pregnancy, during delivery, and postpartum as well. Normally, this anticoagulation profiles are highly, it's dependent on the individual patient, and they are customized to that patient normally, but I discussed the general principles in the earlier lectures for that, right? So now when we come towards delivery, remember delivery needs to take place in where a cardiac ICU is there, right? Where immediate cardiac help can be, because what can go, they can go to heart failure, they can have ventricular tachyarrhythmias, they can have different kinds of arrhythmias, right? And therefore, it's very, very important that a cardiac help or cardiac ICU help is present before the delivery. The best form of delivery is a vaginal delivery, and the best way for that to happen is they go into spontaneous labor. Of course, that is the best. Now, what are the principles that are there during the delivery? Number one, adequate analgesia must be present, right? So a low dose epidural is very good because that can manage the pain very well. Fluid needs to be very, very, very carefully monitored. We should not overload the patient with fluid because they can go into heart failure, right? Oxytocin, it's best to avoid boluses, especially after delivery. It's best to avoid. So low dose oxytocin infusions are okay. Ergometrine, because it fluctuates, makes the postpartum, it can fluctuate, we can increase blood pressure. So therefore ergometrine should be avoided, right? And oxytocin boluses are avoided, and it's best to try with low dose infusions of oxytocin, right? Then throughout the delivery, she should be on a ECG, and very quick conversion or transfer into a cardiac ICU. The facilities must be there during this. So those are general. It's best, sometimes it might be necessary to do an instrumental delivery to shorten the delivery period. So instrumental delivery is not contraindicated, but it should be very, very well done, done very carefully and done by an expert person. And in attendance, there must be experts for these patients, right? Post-delivery, it's always best to monitor very carefully to avoid postpartum hemorrhage, right? And therefore, early intervention is very necessary if some problem happens. So therefore, an obstetrician, a consultant obstetrician input is absolutely necessary during the delivery of these patients, right? If it is a cesarean section, sometimes if there's a PPH, we need to have an early resort to stitches, compression stitches, to avoid postpartum hemorrhage, because if postpartum hemorrhage happens, we will have to give blood, we'll have to give other uterotonic agents, which might be difficult to manage in patients with cardiomyopathy, right? And then after delivery, in the first 24 to 48 hours, they must be in a ICU, right? Where careful monitoring can take place to make sure that she does not go into heart failure and arrhythmias, because auto transfusion of all the placental circulation that was there, right, will be in the mother's circulation after delivery, because the baby is no longer using that, baby has gone out. So therefore, we need to, there may be arrhythmias, heart failures, because the volume to the heart or the load to the heart will increase soon after delivery. So they need to be in a ICU or at least a high dependence unit with careful monitoring for the first 24 to 48 hours. Okay. So breastfeeding is not contraindicated. Medication is not, other medication can be done. So they're not contraindicated. And then, therefore, those are the things that you need to understand about the obstetric cycle in a patient with cardiomyopathy. Post-delivery, they need to go back to their cardiac care, and and they need to be assessed. Remember, the ideal contraceptive measures are what? Normally, levonorgestrel release intrauterine system is a good option, right? Progesterone only pills are good options. Then insertion of progesterone releasing implants under the skin. Those are also good options for these patients. So those are the options that are available for contraception for them. Of course, they might request permanent sterilization as well, which probably is a good option if they have cardiomyopathy, and then because the next pregnancy might be even riskier, right? So those are the general things that you need to know about cardiomyopathy children, and that should cover whatever you require to know about cardiomyopathy. Okay, all right. So that is the first topic, right? The second topic I want to discuss is coronary arterial disease. That is ischemic heart disease in pregnancy. Okay, so that is the second topic. This has become commoner. The reason being, there seems to be a higher incidence of heart attacks, right, amongst the young generation, right? Probably due to the lifestyle changes, probably due to the changes in food habits, right? Probably due to the fact that I suppose the younger generation is under a lot of stress. I don't know, right? So therefore, there seems to be an increase in the number of young patients who are getting heart attacks, right? So now, if you look at these patients, so there'll be a certain amount of patients, for one large portion of patients who will be coming to a pre-pregnancy clinic are the ones who have had a heart attack. Okay, they have had a heart attack, they are on medication, right? And they want to know whether they can get pregnant, right? General advice is, after the last heart attack, it's best to keep at least 12 months, 1 year, before they try to get pregnant. So that is the general advice that is given to all patients. Keep at least 1 year, right? Once you had your heart attack and you have on medication and it's sorted, right? And then if they're asymptomatic, and then they can have 1 year. What is the second advice you need to give? If there is residual ischemia, right, or heart dysfunctions, right, due to the heart attack, then probably it is not a good idea to get pregnant, because they can have repeat heart attacks and heart failure and death due to this. So if they're completely recovered and there's a gap of about 1 year between the last heart attack and now, and they are fully functional now, yes, they can go ahead with the pregnancy after a discussion with the cardiologist, of course. However, the general principle is that if there is residual ischemia, right, they still have pain, they still have ECG changes, there are still echocardiographic changes, right, there are still dysfunctions of the heart, then the advice is no. So that goes in conjunction with the cardiologist. It's best not to get pregnant for the moment, and until they are not symptomatic, right, and the functions are normal, then of course they can think of a pregnancy. Clear? Right. So once they come to the pregnancy, of course, assessment is the priority, right? So you need to assess them. What are the normal assessments? So ECG, chest X-ray, stress ECG, echo, MRI if necessary of the heart, right? All these assessments needs to be made. And then with the conjunction with the MDT or the multidisciplinary approach, especially with the cardiologist, you can decide whether this woman is fit for pregnancy. At the same time, they can be on various medication. They can be on beta blockers, right? They can be on aspirin, they can be on clopidogrel. So aspirin is not contraindicated in pregnancy or to become pregnant, or even clopidogrel, under a very careful consideration, can be continued for a short period. Beta blockers, if they are to continue, remember they can be continued. There are most of the beta blockers are safe in pregnancy, right? However, it can have some adverse effects on the fetus. So therefore, automatically remember, as with cardiomyopathy, if they are on beta blockers, then fetal monitoring and growth assessment is an essential part of the whole complete antenatal assessment of the patient, right? The chances of dying, if a woman has heart disease and becomes pregnant again, the odds of dying varies from about 0 to 25%, right? So that is the risk. The chances of having an obstetric problem, about 15-16%, right? Due to the fact that she's having heart disease, because other things can come on top of that. The chance of the baby dying or having a problem is about 20 to 30%, right? So cardiac disease, and then it's not as simple as a normal pregnancy, because the baby can have problems, the mother can have problems, and the mother can die, right? Of women who has had a heart attack early, okay? But if they are after careful assessment, and if the functions are completely normal, no residual ischemic disease, remember, then they can try to get pregnant if they want. Is that clear, children? So that is the pre-pregnancy assessment. Then they come, once they come, it's the same thing like any cardiac assessment. They have to have the, so definitely we need to know the pre-pregnancy symptoms, and then when they come in the first trimester, we have to check whether they have symptoms. And remember, symptoms are what? NHYA or what is this? We need to assess the modified WHO functional class, right? Plus any symptoms that she can tell us. Pain, ischemic problems, at rest, dyspnea, especially at night, all this needs to be assessed and properly documented. And in each visit, we need to see whether new things come up, right? And of course, MDT needs to be convened to find out whether this woman can go ahead with the pregnancy. As with anything, remember, termination may be advised in the first trimester, but as I told you, there are so many legal as well as moral and ethical problems that comes with a recommendation of termination, right, in Sri Lanka. Then comes when they progress, women who have had, or sometimes they might develop heart attacks during pregnancy. Sometimes it's very difficult to recognize it, because they can come with epigastric pain, chest pain. So all these complications, minor problems in pregnancy may present in the same way, right? A lot of women will have heartburn, epigastric pain, chest pain, discomfort, backache, right? Severe backache. All these may be also maybe due to what it is a heart ischemic heart disease as well. Initially, remember, we also do a risk assessment even before they come of the chances that they might have ischemic heart. What are these? If they are obese, I forgot to tell you this, if they are obese, if they have hyperlipidemia, if they smoke, if they take excessive alcohol, right? All these risk factors that come into play in normal women or men for ischemic heart disease is the same for these women. So therefore, it's very important. Again, I'm talking about the pre-pregnancy, which I forgot, right? So there's general advice about avoiding these for women who has had this event to try and modify their lifestyle, right? Must be given in the pre-pregnancy clinic as well, right? What are the things that can cause more ischemic heart disease, right? In the history of the previous pregnancy, which are what? The history of thromboembolism, right? Then history of postpartum hemorrhage, the presence of thrombophilias, right? Presence of obesity, venous thromboembolism, all these in the history, right? Preeclampsia in the past history, all these are risk factors for a heart attack in the current pregnancy in women who are planning to get pregnant with a past history of myocardial infarction. You all understand? So those also must be assessed in the pre-pregnancy clinic, and then tell the patient, yes, look, if you're obese, if you smoke, if you have had a history of thromboembolism and you have had a heart attack, the chances of you having problems during a current pregnancy is higher, right? And if she has had a postpartum hemorrhage in the previous pregnancy, if she had thrombophilias, if she had those problems, preeclampsia, those problems, or diabetes, or these problems in the previous pregnancy, then of course, plus heart attack, in this pregnancy, all the risk becomes higher, right? So I just got back to the previous because I forgot to talk to you about the risk factors. Risk factors are divided into already pre-existing risk factors plus things connected with the previous pregnancy. Okay, so those are also must be assessed in the pre-pregnancy screening. And now, of course, we discussed the first trimester, right? Is the normal assessment with the MDT with the symptomology, and then we have come to the second trimester, right? Now, if they do get a fresh heart attack, right, STEMI or non-STEMI, right, heart attack, it's sometimes very difficult to diagnose because the pregnancy symptoms may be sort of close to what she might experience from a heart attack. But she has had a past history, then of course we need to suspect that. And the diagnosis of doing it is absolutely the same. Okay, there's no difference, right? So troponin I is as sensitive during pregnancy as it is during a non-pregnant woman, right? So we can use that to diagnose, and of course the ECG changes, the significant ECG changes can also be there during pregnancy. I spoke to you about the possible ECG, about the natural sort of ECG changes in pregnancy, the first lecture, right? Listen to that. But the ECG changes with ST elevation, all the features of heart attack is also present during non-pregnant as well as pregnant people. So troponin I and ECG changes are there, which can be used for the diagnosis, right? Now, once a diagnosis has been made, all the interventions, right, during can be done for this woman having a heart attack or myocardial infarction. All the interventions that are carried out during a non-pregnant person's heart attack can be and should be carried out during a heart attack in a pregnant woman, right? So what are these? So acute interventions, right? Coronary, what are these? Stenting can be carried out. Angiograms can be carried out regardless of the risk of ionizing radiation, right? So angiograms, angiography, stenting, open heart surgery, all these are possible and should be carried out during, one moment, sorry. Right, sorry. Right, the heart attack during pregnancy, right? So every intervention that is used to manage a patient with heart attack is also used for this. What are these? Thromboprophylaxis is possible, anticoagulation is possible with care, stenting is possible, right? Angiograms are possible. All this regardless of the ionizing radiation risk, which is there for the fetus. Still, all these interventions are carried out because her life is at stake, and therefore these are carried out, right? It's very rare for a cardiologist to request delivery. However, if she goes into heart failure and if the cardiologist say, look, she's in bad shape, please deliver because the extra load may be detrimental to her, then of course delivery may be carried out at that point if necessary, right? So if she is near delivery and if she has a heart attack, what do we do? It is recommended to delay the delivery, right? If possible, for at least 2 to 3 weeks, right? For at least 1 week at least, because in the acute stage, unless the cardiologist specifically says, okay, you have to deliver so that the burden on the heart is less, but otherwise usually the recommendation is delay the delivery if possible, right, until she is stabilized and a condition is stabilized, right? So these are the general principles when a myocardial infarction happens during pregnancy. What are the other things? Of course, the fetus must be monitored in a woman who has had a heart attack or hasn't. So beta blockers may be used during pregnancy. So a small forget age must be checked, right? Then frequent visits from 28 weeks weekly. Remember, from 28 about 2 weekly, right? All these frequent visits must be done. And delivery, of course, as usual, the same principles apply. Epidural, very careful monitoring of fluid without overloading, right? Very careful assessment of the labor, continuous electronic fetal monitor of the baby, and continuous ECG for the mother. High dependency or a cardiac ICU nearby with expert cardiac help at any point of time if she goes into arrhythmias or heart failure, or if she has a repeat heart attack, right? Cesarean section is normally performed only for obstetric indications. And if it is a vaginal delivery, that delivery can be shortened by an instrument to prevent a pushing, right? So those are the general things that we need to understand. Oxytocin boluses are avoided, erythropoietin is avoided, slow dose infusions are all right to prevent PPH, oxytocin slow dose infusions, right? So these are the general recommendations, the same as it is for cardiomyopathy, which we discussed, right? And then postpartum, it's the same, cardiac ICU, 24 to 48 hours, thromboprophylaxis if indicated, right? And then definitely after delivery, the same type of, for all heart disease, contraception is normally either depot-medroxyprogesterone is all right, progesterone only pills is all right, intrauterine levonorgestrel releasing intrauterine devices are all right. Even then the implants are all right, right? And of course, for all cardiac diseases, remember, antibiotic prophylaxis may be indicated if there's a risk of infective endocarditis, but that has to be discussed in conjunction with the cardiologist, right? And I told you if it is indicated, I told you what types of antibiotics and the alternatives in the previous lectures, right? And after delivery, of course, we have to, she's sent back to the normal cardiology follow-up. So those are the ones that I needed to discuss about the ischemic heart disease, right? So as you remember now, as we go along, you understand what you all have to understand are the general principles, right? Frequent follow-ups, multidisciplinary input, and the general things, specific things which you need to know about certain diseases. Marfan syndrome, nothing much. Now, Marfan syndrome, what you have to understand is, right, the biggest problem is aortic root dilatation, right? If that happens, right, and they can go into heart failure and problems, right? So therefore, usually what is the cutoff? You just need to remember the cutoff mark trigger. If it is more than 4.5 centimeters dilated, right, pregnancy is contraindicated, okay? And they need to go for their surgery, right? So normally in the pre-pregnancy clinic, and the best way to check for aortic root dilatation, either MRI or echo, right? And then if it is dilated, then of course it is contraindicated. Then they need to go for surgery. If it is between 4 and 4.5 or less than 4, pregnancy is apparently safe. Okay, so therefore they don't need it. But remember, they can go to heart failure, they can go to ventricular tachyarrhythmias, all sorts of problems, right? So therefore, the follow-up for Marfan syndrome is the same as with any cardiac disease. But basically, you need to understand that basic principle about the aortic root dilatation and the cutoff marks. Okay, so those are the things that you need to know about this. So that basically concludes what I wanted to talk to you about heart disease. In sense, I did 3 lectures, right? So it's a bit of a heavy topic, but what you have to understand is you have to get the general principles correct, children. And these 3 lectures, probably you'll be able to answer any question in your final MBBS papers, right? And should be able to at least get more than 50% to pass that question, right? And so you should be able to manage these patients very confidently and in a Pandita manner as post officers when they come to you or when they're in the war, right? That's basically all, right? So it's a short lecture, and then we will move on to what do you all want to do, children? Do you all want to do heart disease, not heart disease, obstetrics? Because there are a lot of requests for small for gestational age, right? that we can do, but then I've been doing obstetrics for a long time. Do you all want me to move on to a gynae topic, or do you all want me to move on to an obstetric topic next week? What? Small for gestational age? Right? Yeah? එක්කෙනෙක් නම් ඔළුව වනනවා පේනවා. Right. So we'll ask an opinion. Yes, Mr. Janaka, what is your opinion? Do you want me to do small for gestation age or a gynae topic? I can't hear you.
Small for gestational age is better.
It's better. Okay. Yes, Mr. Akila.
So small for gestational age, I think it's better.
That's a final answer. I know if when Akila says small for gestation, we'll have to do small for gestation age. So I'm not going to ask anyone else, Akila. Okay. Right. Okay. So we'll do SGA next week. Okay. And so that concludes the lecture. So then, good night.
Good night, sir. Thank you very much.
Okay, good night.
Thank you, sir.